3 or 4 years ago, I think we were frustrated. We could see what was going on in dentistry. We could see what nationally was going on. We could see competitors coming in. We could see it was a very easy market for people to get into. We weren't protected because we were NHS. There was no sacred cows in this. And we needed to be competitive and be out there and competing and, flexing our own muscles. And the way to do that was to start winning tenders. And I think when we won our first tender, it showed and challenged the trust at the time that this is, we're a service that we can do this stuff, which is crucial in taking this forward. We've done a lot of customer care and focusing on customer care, patient care, and looking, obviously, the patient experience is crucial. And we've taken that also from not just from clinical work, but when looking at our dental engineering customers, we're asking them, what was the experience like? Would you recommend us to your colleagues? I feel our USP is the people in it, the dedication they bring to the job. They know it's not a 9-to-5 job, and they take ownership of the clinics. We have people talking about my clinic, my surgery. Where we were and where we are now are two different places, completely different places, and there's lots to do. But the thing is, you can see how to do it. You know what needs doing. You know what the challenges are. We've got a 5-year plan. You can extend that to a 10-year plan. We know what we're going to do and how we're going to do it. And we know we've got the tools to do it now. We've changed the emphasis from being a very top-down model to having practice managers, dental nurse team leaders and staff having targets and budgets at a local level. So they've got more control of what's going on because they're on the front line. They know their service better than I do. The other important commercial venture is dental engineering, where we saw an opportunity where we were using a dental engineer to manage our dental equipment breakdowns and maintenance, but we were paying for that service. So we brought that service in-house, we put some money into it, and now that service is offered externally to other dentists. The advantage to that is if you close a surgery down for a day, it's about £1,000 of lost income. So if you balance that up against having an engineer call-out fee and getting that surgery up and running, then you can see there's a commercial benefit to the dental practice and to us in having that service available. You know when something is well, when there's a great atmosphere, team atmosphere, and things are slick and they move properly.
Well, the organisation was obviously looking at opportunities to extend its community services outside of Kent. And the opportunity arose for children's therapy services in East Sussex. And it was felt that there was a potential natural collaboration with our own therapy services. It was a very similar style of service, and it was on our borders. So it was felt that there could be smooth opportunities for travel of staff. So there was some pre-planning to actually work through what our service model would look like and what service structure we could afford. And also if whether or not we could use some of our sort of Kent work to be able to transfer down into Sussex so that would make our lives easier so that we weren't having to reinvent the wheel. So we proceeded with that and we were successful in winning the tender. Children and families had been waiting up to 2 years to be able to access an appointment with a therapist, and that clearly wasn't meeting the needs of those children, some of whom didn't actually need a long-term involvement. They just needed a short piece of targeted intervention in order to promote their development or engage them within a school or nursery setting. So actually to wait 2 years to be able to access that clearly was a huge concern for the local county and the local commissioners. So that was one of our challenges. So looking back now, I do feel very proud of the staff in Sussex and how they have risen to the challenge, because it has been very difficult for that staff group. They, through no fault of their own, there were huge challenges and pressures on their service in East Sussex. And then they had to face TUPE transfer to a completely new organisation that's not completely on their doorstep. And they really have continued to put children at the heart of everything that they do and go through restructure challenges. And I'm very proud of the way that staff group have not downed tools, and they've kept their eye on the prize, which is trying to deliver the best services we can for children and young people. And it's enormously satisfying as well for children now to be able to be assessed within 18 weeks in East Sussex. And it's trying to sort of really educate staff, I think, about what commission contracts are about, what key performance indicators are and why we have them. And what quality standards we've got, both locally and in a commissioning environment. And I think if staff had a greater awareness of the fact that we were monitoring quality standards, that they may feel slightly more comfortable with the fact that we're not going to blindly follow a commissioner's intentions, but there is a responsibility to try and do the best that you can with the service financial envelope that you've got. And as long as you've got a good relationship with the commissioners and staff trust you to have a good relationship with the commissioners, then if you are noticing trends and real significant pressures in a service and you've got good metrics around those, then the staff can trust you to take those challenges back to a commissioner and have a discussion about how you can meet them.
Commerciality in the Enhanced Rapid Response team has been absolutely fundamental. I think from the start, the CCG actually approached us. So our commissioners came to us and said, we have a vision for urgent care. We want to make sure that urgent care can be adaptable, can be flexible, can be agile. But most of all, we want to try to keep patients out of the acute trust. And for a number of our patients, the last thing that they want to do is end up in hospital. So we met with them and we talked about how we might be able to develop services in the community. This was a whole new service where we've introduced for the first time consultants and doctors and paramedics into our teams. And that's made a huge difference in terms of the level of complexity that we're able to deal with out in the community. We knew it was a pilot. We knew right from the start that they would be tendering this service ultimately, and it will include what was our rapid response service as well. So we had a risk in terms of losing an element of the service that we already provided prior to this. But of course it was a huge opportunity. It's not just about saving money. Their priority was around high quality care in the community and avoiding the admissions. So the money saving element was around avoiding patients going into hospital, but the quality of care for patients is huge. Our patients thank us for not having to go to hospital, and that's a real difference in terms of patient care.
When I came into post, I was given a very clear remit, and that was to overhaul the service. Went through the whole process with a fine-tooth comb, questioned pretty much every job that we did, why we were doing certain things, what led us to do that way. And then we just sat down as a collective, as a team, to come up with an efficient way of manufacturing. You always come across the sort of the obstacle that we've always manufactured this way. Why should we change? People need to be given a reason to change. You need to challenge their sort of thinking. So the traditional way of actually manufacturing orthotics is that you will have a shell, and then you build up your shell with all the various layers that particular patient requires. The way that we're actually manufacturing these insoles is everything will be embedded within one unit. We've reduced lead times from 12 weeks down to an average of 2 weeks. So for our patients, they get a far better service. We've also improved the quality of the orthotics that we're manufacturing such that they last longer, so the patient doesn't have to come back so often. We've also reduced the cost of manufacturing because we're manufacturing them quicker, so they're not so labour intensive. We've brought in more automated processes such that actually we can reduce the double handling aspects of the role as well. We've also done a lot of innovation and development work with regards to actually transforming the service. And one of those pieces of work that we did, which we started about 2 years ago, was looking at 3D printing, not standing still, but again, using that new technology to improve our service. But what that does actually give us, it actually gives us a product that we can then sell on, outsource, and generate income from.
I remember there was just a desk, a computer, and a chair. That was about it. There was no scope for the service, so it was a wonderful opportunity to develop this service from zero, if you like. Most of the services at the time were in secondary care, so it was unique because it was a joint paediatric and adult service. Well, the service started with one nurse, which was myself, and within the first year it was providing clinics in secondary care and home visits and training. And then within 3 years there was 3 nurses, which was based on evidence that the service were effective and was meeting commissioners' requirements, but most importantly meeting patients' needs. Commissioners have asked us to become a Kent-wide service, and we will be holding nurse-led clinics, home visits, providing training to help patients who have prolonged seizures. We can train people to give them the right medication to prevent them going into hospital.
I think we've been talking about commerciality for a long time now. I don't think this is anything new. I believe in the 1990s we talked about competition quite a bit, and we've been talking to our staff about competition. Back then, in the 1990s, the competition was very much other NHS organisations. Now, however, we have lots of enterprises who are prepared to come into the market. It's about talking to staff, making them understand just how important it is that we actually get that feedback from patients, that they do take time to engage with patients in order to get that sort of feedback, because far outweighing any financial issues, far outweighing probably anything else, the patients coming back to us saying, this was really good, I didn't have to go to hospital, I feel better quickly, and I'm in my home environment. I haven't had to leave my dog or my cat.
Falls Prevention Service was set up in 2007 to bring 12-week exercise classes to over 65s. Now, at the moment, the way we get our patients is by going out and promoting the service proactively. We're looking for people who haven't necessarily fallen, who are maybe a bit wobbly on their feet, maybe have osteoporosis, maybe they feel a little bit worried about falling over. We're always assessing for new people, we're always bringing people on, so long as we keep that activity up and get people through, and then so long as we're actually meeting our guidelines, our key performance indicators, that also leads us to be able to prove to the commissioning bodies that what we're doing works.
I think when I started, there was lots of issues with team morale. They were struggling with the workload. They might have a long list of patients to see. They felt that it was really difficult. They weren't given the care that they wanted to give. As nurses, obviously, we want to give good, compassionate care. So actually, we've utilised those resources across the whole of the team now, the whole of Herne Bay, and actually we can pull on those resources for the patient. So now morale has improved and we can see improvement in the quality of care for the patients. Another care we provide is end-of-life care, palliative care. So more patients now want to end their days at home with their family around them and friends. So examples of that is when patients would normally have been admitted to somewhere such as a hospital, but now we've increased our input. GPs saying, Hannah, can you prescribe this syringe driver for their end-of-life care, for pain relief, to make sure they're comfortable in the last days of life. So the GPs now trust us, and the patients know who to contact and know that actually the nurses will be there at a drop of a hat, and they're obviously our priority. A lady we've worked with recently who was quite poorly for quite a long time, a few months, and we were going in daily. And we built up a rapport with the family and the husband, and it was difficult at times, but the GPs would come to us actually to say, what's happening with the patient, and because they knew that we'd built up that rapport with that patient. So actually we were having difficult conversations with the family, and that on the last day, that patient died peacefully at home, and the husband was really, really grateful for the care.
I'm very proud of the epilepsy team, who not just work really hard, but they actually show the value to the organisation. My proudest moment was when the service was recognised, it was up and running, and I was able to feed back to patients what we can do and where they can go for support.
From a service point of view, pride-wise, it's seeing a patient, Mrs. Smith, Mr. Jones, going from one level and belief to another level and belief in their own abilities, and actually seeing somebody become a different person, if you like, in some circumstances. We had a lady on one of our classes, she's 95 years old, struggled to get out of a chair. And she stopped me in the middle of a group class one day, before we started the class one day, stopped everybody. She said, "Wait, stop." And she stood up, threw her arms in the air and went, "Ta-da!" And that was about 8 weeks into the class. And the whole class cheered at her, and it was such a proud moment for her. And because of that, it sort of really makes you realise that what you're doing is a worthwhile job.
I think the team go that extra mile. They go beyond the call of duty, and especially if someone is palliative and they know that actually they need to go that extra mile, and now they can have that time and give that quality care. And that helps morale within the team because they know that they can provide that care and they know that they've given that compassion to that patient and the family. So that affects the whole team really, and then we can feed back and know that we've given excellent care.
I suppose a take-home message that I'd like people to take away from this is that we've made lots of small changes, and all those small changes have actually sort of added up to making a very big impact on our service, so that it's a case of whatever the change, however small, make that change.